Just quickly, the company was founded in its current form back in 2008. I was a venture capitalist at the time and led the first institutional round that got the company started. What we're going to be talking about today are daily disposable contact lenses, which in itself is not something special. What is very special about our lenses are the optics that we put into the contact lenses. Two large market opportunities that we're after with our contact lenses. One is called presbyopia. Presbyopia is the loss of near vision in people who are over the age of 40. It's virtually everyone over the age of 45 suffers from this progressive loss of near vision. The other target market that we're after is something called pediatric myopia. Pediatric, of course, being child, myopia meaning nearsighted. These are children who can see things up close just fine, but they can't see things out in the distance. We IPO'd on the ASX. We listed in March 2017. In that IPO, we raised a little over $33 million Aussie. All of the products that we're going to be talking about today are cleared by the FDA, the Food and Drug Administration in the United States. And as of last week, we're very excited to announce that we also just received our CE mark, which is the clearance to go into Europe. That also opens up Canada, Australia, and some Asian nations for us as well. The use of proceeds over the past year since the IPO, though, have primarily been used to expand the sales and marketing in the United States and to prepare for even larger launches internationally. Just sort of what we've been up to over the past year since the IPO. Again, sales and marketing is the primary use of proceeds. We went into last year with 5 sales representatives that were in the United States selling our products. Post-IPO, we added another 20, so we're currently at 25 sales reps selling our products. The target is 45 sales reps by around mid-year. Nothing magical about that 45 number. It's an arbitrary number that was set so that the raise of capital would be in a reasonable place. A typical contact lens company in the United States will carry around 250 sales reps to completely cover the United States. So lots of growth opportunity in front of us should we choose to exercise it above the 45 reps. The way these sales reps normally work is that they'll carry between 100 and 200 optometrist accounts per sales rep. And at maturity, which can take between 2 to 4 years to get to, each of those sales reps can generate between $5,000 and $12,000 a year. If you look at a mature contact lens company like Bausch & Lomb or Cooper Vision or Vistakon, 3 of the large majors, or Alcon, they'll typically generate around $1 million to $1.1 million per sales rep in their U.S. sales, to give you a sense of what the scaling looks like. Obviously, in very rapid growth mode right now. One of the metrics that we're tracking right now as we start to build up new accounts and these reps go out there and start to open up new optometry accounts is something called active accounts. Active accounts are accounts that actually ordered product in that quarter. And the incentives for the sales reps in 2017, of course, is to get as many people out there using the product as possible. And as those sales reps start to mature a little bit, they start to shift towards an incentive structure that is depth versus width. So just so you understand the opportunity a little bit, it's often helpful just to understand how the eye works and producing clear images for our brain to look at. In this diagram, the left is the front of the eye, the right is the back of the eye. That's the path that light takes in the eye. The reason we see objects is because light bounces off of objects and enters our eye. And the light that comes off of an object enters our eye at all different angles. And the job of the eyeball is to take those light rays that are traveling in all different angles, bend that light so that all of the light rays come to a singular point and converge. And that point is at the back of the eye, and it's on a structure called the retina. So the retina is where the image is collected and transmitted to the brain for you to look at. If that convergence point of those light rays is either in front of or behind the retina, that's a blurry image, just that simple. There are 2 lenses that are in the eye to accomplish the convergence of light rays. The very front lens is called the cornea. This is the very front surface of your lens. If you were to stick, or of your eye, if you were to stick your finger into your eye, you're actually touching the cornea, which is a clear lens. The crystalline lens is a second lens that's immediately behind that, and it's really important, the distinction between these two. The crystalline lens is different from the corneal lens in that it is attached to muscles and it can change shape based on how close an object is to your face that you're trying to see, okay? So some of the things that can go wrong earlier, I told you that we're after two large market opportunities, presbyopia, which is the age-related loss of near vision, and pediatric myopia or nearsightedness in children. We'll talk about each of those in turn, but first just diagrammatically so you understand what's happening. The closer an object is to your face, the higher angle the light rays are entering your eye, okay? Normally it's the job of the crystalline lens when things are really close to your face to change shape so that those high angle light rays end up converging in the back of your eye so that you see things clearly. Unfortunately, when people get over the age of 40, the crystalline lens starts getting stiff and the muscles that support it start getting weak, just like a lot of other things in your body. And when an object is really close to your face and those light rays are entering the eye at really high angles, the crystalline lens doesn't bend enough to be able to bend those light rays to get them to converge at that point on the retina. The light rays don't get bent enough, they end up converging behind the retina, so near objects look blurry. A patient who is over the age of 40 having trouble seeing up close will be prescribed something called plus lenses. What plus lenses do, and whether it's in a form of glasses or contacts or whatever, is increase the amount of bend in the light, increases the angle of the light coming into the eye so that they converge at the retina and you can see things clearly. Okay. Separate from that, nearsightedness. Nearsightedness means that you can see things up close, you can't see things at distance. And the reason that happens is that the eye has grown too long from front to back. And because it's grown too long from front to back, that convergence point has been left in front of the retina, okay? It's in front of the retina, that's a blurry image. And it's only for distance objects and because the eye is too long. What is needed for somebody with myopia is something called a minus lens. And a minus lens unbends the light slightly and takes the convergence point and moves it back to the retina, once again giving a clear image. As we get through the presentation, you're going to hear this plus and minus quite a bit. So just sort of commit to memory, if you could, now that a plus lens moves the convergent point towards the front of the eye, and a minus lens moves the convergence point back towards the back of the eye, okay? So now a little bit deeper into presbyopia. So if at the age of 30, if you're wearing contact lenses or glasses to be able to see distance and you shift your gaze downward to a menu or a book or a phone, that crystalline lens will immediately change shape and allow you to see things up close with no problem. You don't notice it happening. It works really well. By the age of 40, those same contact lens or glasses are typically still working well so that you can see distance. But a lot of us start to notice in restaurants or in dark lit areas, things that are up close start getting a little bit blurry. You know, you're looking at a menu, you're having to hold it further away from your face. You're sitting in a restaurant, you see people doing this. You know that they're over the age of 40, but probably under the age of 50 because they can still hold something at a point where they can read it even if it's further away. By the age of 45, most of us can't see anything within arm's length. And this is the person in a restaurant who looks at the menu, sets it down, they order the special because they can't read the menu, and they don't want to put on reading glasses and look like they're over the age of 45 or 50. The same contact lens or glasses can help you see distance, though. Those are probably still working fine. It's just those near things that you've lost the ability to see. But for the patient who's been wearing contact lenses to correct their distance vision, probably since their teens or even before their teens, they now have a dual need when they're over 40. They need something to correct that blurry distance vision, to correct the myopia. They also need simultaneously something to correct the near vision. There's a contact lens design called a multifocal contact lens design. It's been available from the major contact lens companies for a very long time. The problem that we set out to solve at Visioneering is they do not work very well. They've only been able to penetrate the market by about 10%, and it's because they do not do a very good job. They actually do a very poor job of providing simultaneous distance and near vision. The patient almost always ends up having to sacrifice one or the two. Usually it's the distance vision. For the practitioner, this is pretty frustrating from two perspectives. First, they have an unhappy patient, and many times they weren't able to sell a product to the patient. The other challenge for the practitioner is that to get to that point where the patient either accepts the compromise in the vision or rejects the lenses altogether, can take between 2 and 5 visits. In the United States, Australia, most industrialized nations, the way the billing works for an optometrist is when they're working on a problem like this, they're only charging for the first visit. So that second, third, fourth visit, patient or the optometrist starts losing money. So anytime a medical product provides a poor result for the patient and a doctor loses money, it's probably not going to do well, and those products have not done very well in the industry. So to explain how our lenses differ from this, it's really fun to understand how an aperture works. And an aperture is it's a method that's been used in photography for over 100 years to provide simultaneous near and distance clarity. In a way that works is this. So an aperture is just a pinhole. So you could take a paper clip, poke a hole through a business card, and that's going to be an aperture. And you can take that and use it to look at things that are really close to your face, and they'll actually be really, really clear no matter how close to your face you get with an object if you look through that pinhole. And the reason that happens is that, remember, objects that are close to your face are entering your eyes at really high angles. Crystalline lens can't bend that light enough to get a near object to come in clearly at the back of your eye. So with a pinhole, if you put it all the way up in front of your eye and look through it, what ends up happening is those high angle light rays are blocked by the card or blocked by the mask and never enter your eye. The only light rays that enter your eye are the light rays that are traveling straight back through the pinhole into the back of your eye and do not need to be focused. It's not an ideal way to be able to see things that are near and far away, but it works okay. But it's an important mechanism because this is the premise that we started with when we designed our contact lenses. So if you understand that, you'll understand how our contact lens works. And that's on this slide. The way that our contact lenses are designed is in the very center of our contact lenses is the patient's distance power. So if the patient has been wearing a -4 in their glasses since childhood or early adulthood, or -4 in their contacts, they're going to wear approximately a -4 in our lenses as well. As you move away from the center of our lenses, the power rises in the plus direction very rapidly away from the patient's prescription. So when the patient looks through our lenses, all that is clear in that lens is the very center of the lens, which provides this nice clear image coming through. Everything else, because of all the plus power, is blurred. And what happens in a patient's brain is brains are incredibly efficient at filtering out blur if they have something clear to look at. And so you get this nice clear image coming through the center. Everything else we very intentionally blur. That everything else gets blocked by the brain, so that all you see is what's coming through the center. Effectively, that is an aperture. It's the exact same thing that I described using a pinhole, except for we accomplish that virtually in the brain. The title of our patent is actually Induced Apertures and Optical Systems. So we're actually inducing an aperture. The effect of that in the patient is very good near vision, simultaneous with very good distance vision and everything in between in a really simplified design. So the only prescription in our lens is that distance prescription in the center. Now that you would contrast with the other competitive contact lenses that are multifocal in that those lenses are built in concentric rings. The very center of all of the other presbyopic contact lenses is a near power in the very center of the lens, and a concentric ring to that is a distance power, and then sometimes they'll alternate between those. The reading powers will come in different powers in the other lenses, so it can be low, medium, high, or even up to 6 different reading powers for each and every distance power that can be tried on a patient. So the complexity is that the doctor optimizes distance power, reading power, then they have to permutate between the distance prescription and a near prescription in those competitive lenses, and it takes a long time to do that, and it takes a while to figure out for each patient what they're willing to tolerate and compromise. There's only a single prescription in our lens that takes care of both the distance and the near, and does it in a way that the other ones just can't accomplish clinically. So this is results from our clinical trial before we launched the product, and what you'll see on the far left, the dark blue lines are the competing products. The light blue bars is Visioneering's lenses, And on the right, you'll see under distance vision or above the distance vision label, those are patient readings of distance vision using ours or the competitive products. What you'll notice on the left is that near vision. So we provide very high quality distance vision simultaneous with very high quality near vision, where the other products, if they're going to give you good distance vision, they cannot provide you with good near vision. And that's the compromise of those products that we set out to solve for these patients. Not only is it a better result for the patient because they get good simultaneous distance and near vision with our lenses, it's a much better experience for the practitioner, resulting in much fewer visits to get our lenses optimized. So with the competing products, it's not surprising to see an average of 2.4 visits to optimize lenses for the market leading product, multifocal product, whereas ours are typically optimized and sold to the patient in the first visit. In the United States, we have 8 million people over the age of 40 who are already wearing contact lenses. Most of these patients are wearing distance contact lenses only, and then putting reading glasses over the top of those contacts when they want to be able to read. The sell to that patient is, since you're going to wear contact lenses anyways, wouldn't you rather wear a contact lens that's going to take care of both your reading and your distance needs? And of course, that's the case. That's the low-hanging fruit for us because they're already wearing contacts. There's a lot of upside to that, and that's the $3.4 billion of addressable market in the United States is just that 8 million. There's an additional large upside to that, and patients who used to wear contact lenses before they became presbyopic, but came out of contact lenses because they didn't like the solutions that were available when they became presbyopic over the age of 40. We'll transition now into pediatric myopia. Again, this is nearsightedness in children. Nearsightedness in a child is typically detected by a teacher or a parent somewhere between 5 and 10 years old. Somebody will notice that the child is squinting a lot, they're having trouble seeing the board at school, they're having trouble playing sports. It's a progressive disease. Once somebody is nearsighted and detected in childhood, they'll just keep getting worse until somewhere between 18 and 25 years old. Their body stops growing, their eyes stop growing, their eyes stop getting longer, and their vision will stabilize. In the meantime, between those two periods, though, between the time of being detected and the time they stop getting worse, their vision is getting worse every year. So every year they're going back to the doctor, they're getting more powerful glasses, more powerful contacts, and it's very expensive for the parents, very inconvenient. The expense and the inconvenience and the cosmetics of having thicker lenses every year, though, is not the medical problem. From a medical perspective, the problem is that the worse the nearsightedness gets, the higher at risk that person is throughout their entire lifetime of blindness. And that blindness comes in the form generally of retinal detachment. Remember, the retina is a structure on the back of the eye that collects the image and sends it to the brain. And people who are myopic, the more myopic they are, the more likely they are that that retina at some point in their lifetime comes off the back of the eye. And that is a blinding or near blinding event. It can sometimes be fixed by surgery, but not without a great loss of visual acuity. Cataracts and glaucoma are also very, very common in people who are nearsighted. And again, the risk of these things is higher and higher the more nearsighted the person is. So the medical goal is not to only provide clear vision, which is necessary so the kid can see, but ideally to actually slow down the rate of worsening of the nearsightedness so that they stay in the lowest risk categories possible. So there are some marketed solutions that aim to do that. One of those is called atropine. Atropine is a drug. It's not actually made for the eye, but you can find somebody to mix it up for you. Some optometrists will make atropine eye drops for you. There are some side effects. These can burn when they go into the eye. They can also cause light sensitivity in children. They will, though, slow down the progression of nearsightedness in children between 30 and 50%. Not great, but it's better than nothing. Another thing that's often tried, it's more common than atropine, is something called ortho-K. The K stands for keratology, so it's orthokeratology. These are hard contact lenses that are placed on a child's eye before they go to bed at night, and actually over the course of the night reshapes the front surface of the child's eyeball. In the morning, the lenses are popped off, and through at least part of the day, the child can see clearly without glasses or contacts. And importantly, they can slow down the progression of the nearsightedness again between 30 and 50%. Again, helpful, but not ideal. These lenses are very expensive. They're prone to breaking. They're prone to getting lost. And anytime somebody is wearing a contact lens overnight, it increases the risks of infection and inflammation. So they are used, again, it's better than nothing, but hasn't gained widespread market adoption. What the market and medical community have been asking for quite a long time now are soft contact lenses that can simultaneously provide clear vision to the child and correct the optical risk factors that are generally thought to be associated with the progression of nearsightedness. So in other words, provide good vision, slow down the worsening of the myopia, and also it really needs to be in a daily disposable format because children are not well known for their outstanding hygiene. So it's much better if the lenses can just be taken off at the end of the day and thrown away. This has been a difficult optical problem to solve for the following reason. Remember that I said that myopia occurs because the eyeball is too long from front to back, leaving the convergence point of the light rays in front of the retina. To correct the vision, one must use minus lenses, which move the convergence point back to the retina, provide a clear image. One of the drawbacks to doing that, though, is that all of the peripheral light rays, which are depicted on the slide deck in gray, are pushed back at the same time. So while you've taken the central light rays and moved them back to the retina to give a nice clear image, these peripheral light rays get pushed back as well and end up converging behind the retina, where it is thought that they tell the eye to continue growing. And these aren't light rays that the child can see, but they are light rays that are hitting the retina and having a physiological anatomical effect. So what the community has been asking for, and people have been trying to solve for a while, is how do you move the central light rays back to provide a clear image, but simultaneously move the peripheral light rays towards the front of the eye where they remove the signal for growth. So you would do that, obviously, by having a lens that is minus in the middle to move the central image back, but peripheral to that plus power to move the peripheral light rays inside the eye, inside the retina. And if you remember my description of our our presbyopia lens, that's exactly what it is. In the very center of the lens is minus power, and peripheral to that is a bunch of plus power who in the presbyope provide simultaneous near and distance vision. But in a child, solves the dual purpose of moving the central image back so that they can see, simultaneously bringing in the peripheral light rays inside the retina to remove the signal for growth. And so, people, when we launched our lenses for presbyopia, looked at the design and said that may work in children to slow down the progression of myopia. So what they started doing is they started taking our lenses that we were selling for presbyopia and putting them onto children and tracking what happened. And it was pretty interesting. Back in March of last year, when we actually IPO'd the company, there was data that was collected by practitioners on 14 children. And in that data, they showed a 94% decrease in the rate of progression of nearsightedness in children wearing our lenses between 6 months and 2 years. That was pretty incredible. But the number of children was small. It was only 14. It's a very reasonable criticism. It was not enough to go into a peer-reviewed journal at that point. In October of this year, practitioners got together again and pooled children again and brought the number up to 32. So 32 children in a series were published in a peer-reviewed journal, Eye and Contact Lens, back in October. And this is what they showed, a 96% decrease in the rate of progression of nearsightedness in those 32 children, which is pretty impressive. Just last week at a conference called the Global Specialty Lens Symposium, a group of practitioners got together and again published data of our lens in children and showed a 97% decrease across over 90 children wearing our lenses. So now we've almost tripled the number of children for which we have data, which gets to be pretty impressive. In that study, they're showing 98% of children either slowed down or stopped in their myopia progression, with 81% of them completely stopping or reversing. So from our perspective, this is pretty happy data. And again, this is using the exact same contact lens that we sell in presbyopia. We don't package it any differently. We just present the data, and the doctor has access to the data through their usual industry contacts. 5 million children in the United States who are already wearing contact lenses to correct their distance vision. So that's, again, the low-hanging fruit for us that represents around a $2 billion market opportunity for us. And again, potential upside to that 5 million are kids who are wearing glasses to correct their distance vision, but not getting any therapeutic effect out of that relative to their myopia progression. And, those children could be wearing contact lenses that not only correct their distance vision, but also have potential through the addressing of the optical risk factors to slow down the progression of their myopia. So just with regard to international expansion, if you look at the Asian countries, the Asian countries suffer disproportionately from nearsightedness. 80 to 90% of children in most of the industrialized Asian nations suffer from nearsightedness. Singapore has actually declared nearsightedness in their children to be a healthcare epidemic. And so it's a really big deal. Even in the United States, we've seen our proportion of children who are nearsighted double in the last 30 years, and now a third of our children approximately are nearsighted. And in Australia, which has historically enjoyed some of the lowest myopia rates in the world, has also seen a doubling of the percentage of children who are nearsighted. So this is a really big deal around the world. We do plan on launching our products internationally. We do not plan on building sales forces internationally. Again, we did just receive our CE mark, which clears us to launch the product in Europe. We'll do that through distribution partnerships in Europe, in Canada, and potentially Australia and Asia as well. And just really quickly on other products that we're either selling now or have in the pipeline, Sphere products are just very simple contact lenses for the correction of distance vision. They're commoditized products, but it's very important to carry a full product line for the optometrist, so we do sell Sphere products. Toric lenses are for patients with astigmatism, and that is a product that we'll be launching later on in 2018. And then the contact lenses for people who are presbyopic with astigmatism and nearsighted, which is a very complex optical design, is a product that we're looking at launching at 2019, end of 2018. But our sort of bread and butter product is the multifocal contact lenses for presbyopia.